If I am the candidate, what I do is, I will just come to the by the foot end of the bed. I will see that his both hands are placed symmetrically on either side, and then I will top to bottom, I will see at the same time, I will just look for the, while I am at the foot end of the bed itself, I will see for the dependent edema of the feet, and then I will see the respiratory movement, whether he is tachypneic or dyspneic, whether there are any gross abnormalities of the chest wall, where the trachea seems to be central, and also look at the supraclavicular fossa, whether there is any asymmetry in the supraclavicular fossa, infraclavicular area, mammary area, inframammary area, axillary area. All these I have examined, and I find that there is no abnormalities. Okay. Suppose if there is a marked wasting of the left infraclavicular area with a drooping of the shoulder, okay, then I think the patient has an upper lobe pathology. Okay, then what I will do, I will start with the anterior chest wall examination. If I don't have any clues pointing towards the pathology in the upper lobe, I will not waste my time starting with the examination of the anterior chest wall. I will straight away, I will confirm my inspection findings by palpation over the neck, and then I will go to the back to do detailed examination, where I will pick up all the signs and I will come to a diagnosis. So this is the important thing which you have to look for. If there is a gross abnormality of the anterior chest wall suggesting that there is some pathology in the upper lobe, then I will concentrate on the anterior chest wall. In this particular patient, I am not finding any asymmetry between the supraclavicular fossa, infraclavicular area. If you are not able to see the supraclavicular area, you can ask him to go up a little bit more. Now I can see the supraclavicular area is symmetric. Okay, so I am confirmed that there is nothing abnormal pathology in the arm. So I will come nearer to the patient. I will examine his hand, and I will just, while looking the pulse for a few seconds, I will look at the clubbing. Please don't waste your time looking for the clubbing. If there is an overt digital clubbing, you can say, okay, the digits are clubbed. And if there is a subtle clubbing, you can say, I'm not sure of the clubbing, maybe early clubbing is present. But don't waste your time 1 to 2 minutes looking by tangential and then looking up and down and then lying down and looking at the clubbing. There is no need. Okay, so please, I have seen many candidates coming and wasting 1 minute for the clubbing alone. There is no need. So I have looked at the clubbing, and then I will look for the flap, the flap of the respiratory failure. Just 1 second, finished. Then I will come and confirm my inspection finding. I will just look for the trachea. It is central. Okay, if it was shifted, the other clue which you get is the sternocleidomastoid muscle insertion. The clavicular part of the sternal part of the head will become prominent. So I have made sure that the trachea is central, and I will just run my hand on either side of the neck looking for any lymph nodes and then supraclavicular area. Then I will ask him to open the mouth, the tongue for the cyanosis. Okay, I have finished the examination, and then I will comfortably go to the back because I know the signs are going into the back. Then I will start with the chest movement. Okay, you can use, if you want, you can come nearer. You can use, but always remember, you have to take care of the comfort of the patient. The uncomfortable position, if you place the patient, you will fail in the exam. So the comfort, and the patient should not have any pain while examining. So you can keep a fold of skin, you can keep a fold of the skin between the thumb and ask him to take a deep breath. Then here and here. See, this skin fold is important, okay? So that will give you an idea of the chest movement. So if the chest movement is diminished on either side, you can pick up by this. Then you do the percussion, okay? Percussion carefully, and then you auscultate over the ear. So you better always remember suprascapular area, interscapular area, infrascapular area. And then you ask him to keep hand here, the axillary area, upper axillary area, the lower axillary area. This you should finish in the back examination. And I already mentioned to you that what all things you should concentrate while auscultation. Okay. Now I have picked up all the signs. So I have examined, I did the palpation, I did the percussion, I did the auscultation. I have all the findings in the back. Now I have enough of time. I will just come to the front, and again I will do this brisk examination of the movement. There are two sides. and then I just do a percussion, and then I do the auscultation, and I finish up all the findings within a few minutes time, and then I will collect. Before the examiner says 2 minutes, I may finish sometimes, and then I will collect the findings and then present to the examiner with all the relevant positive signs first and very relevant negative signs. Okay, for example, a patient is dyspneic, and if you want to say there are no signs of respiratory failure, but these are the findings I got. So you should say like that, not to say that all the negative findings first and then the positive signs. We always tell like the candidate, please come out with the positive signs. Then you come out with the positive signs and very relevant to that particular patient, negative signs only you have to mention. For example, you are suspecting an interstitial pulmonary disease, and then there is no cyanosis. You can say there is no cyanosis even though the patient has got interstitial lung disease or bronchiectasis and clubbing. Like that you have to correlate the diagnosis, pathology with the clinical finding and come out with the negative findings. Okay, this you will get only 6 minutes. Any doubts you can ask me now.
So we should start with bag as long as there is no clear pathology from the
That's right, yeah. If there is no pathology, there are no clinical signs to guide you or to tell you that there is a pathology in the upper lobes, there is no meaning in wasting time in the anterior chest wall. That's what I told you, if I had seen a wasting of the infraclavicular area, or if I have seen a hollowing of the right supraclavicular, left supraclavicular fossa, or if there is a big scar with a drooping of the shoulder, then I may consider examining the anterior chest wall. Otherwise, I will go to the back and then finish and then come to the front. Now, regarding the supraclavicular fossa auscultation, again, I am telling you, don't waste your time in supraclavicular fossa auscultation, because for a student, actually, we are expecting the candidate, undergraduate student to auscultate over the supraclavicular area. But for this 5 minutes examination, you can start with the infraclavicular area. You're going to pick up the bronchial breathing or any abnormality in the infraclavicular area, so you need not do the supraclavicular auscultation. So don't waste your time for the supraclavicular area auscultation. Again, vocal fermitus and vocal resonance. Both of you see the systematic way of undergraduate student, we expect both to be done, but in a 5-minute examination we are expecting only you to do one, that vocal resonance will be better. So vocal resonance always should be compared to either side. Okay, so that's all we are expecting you to do.
Sometimes we make our examination little complex by examining the lymph node from the back, but you show that
this is enough.
Screened.
Very, this is more than enough, because if there is anything abnormal you can see, that's all. You don't have to waste time, because this is a very short exam where we are expecting you to pick up all the positive signs, and we are keeping some patients with the relevant positive signs only, so you don't have to look for any complicated signs or any abnormal, very subtle signs. You don't have to worry, because before the exam we have a calibration where both examiners will come to a conclusion that if the candidate misses these findings, we don't have to fail. For example, I will tell you, you can get a cardiac syndrome with the bronchiectasis. Okay, so even if you miss the dextrocardia, we are not going to fail you. You will get, if you pick up all the signs in the lungs, you are going to pass, because this is a respiratory system station. So in the last exam I have seen one candidate failing in the exam because he heard from somewhere that there is a dextrocardia with the cardiac and bronchiectasis in the exam. So he came to us, and then there was a patient with bronchiectasis, but he was not the case with the dextrocardia. So what he did, he examined, he just palpated here and then said there is a dextrocardia and cardiac, and he failed, because we know that he got a clue he heard something from the other candidates. So unbiased, don't listen to anybody. Unbiased, you go and examine the respiratory system. We are not going to fail you. We will give you full pass if we pick up all the signs which are supposed to be picked up by you in the respiratory system. Don't concentrate on the cardiac, because there is another station for cardiovascular system examination, so we are not bothered about that.
Is there any role of GFP examinations?
No, in the respiratory system, no. You can just look at this. If you are suspecting a cardiac failure, Core pulmonale, for example. Core pulmonale is there, and if there is a marked elevation of the JVP with a tricuspid regurgitation, then of course you can say that JVP is raised and then the patient is having prominent venous pulsations, and then that's enough. We are not going into the details of the cardiovascular system, because here we are concentrating more on the respiratory system.
On the presentation, how we will start by what is the systematic presentation?
Yeah, so you can say, okay, I have examined the respiratory system, the chest of this or respiratory system or lungs of this particular patient is not dyspneic at rest, and I don't find any signs of respiratory failure. The trachea seems to be central, and on percussion, suppose if there is a impaired percussion note in the left infrascapular area, I will say, okay, there is a dull percussion note on the left or right infrascapular area, where I am hearing the breath sounds almost absent or diminished with a reduced vocal resonance, and I could not hear any added sounds. So my first diagnosis is there is a pleural pathology. It could be either a pleural effusion or a pleural thickening. This way you can present. So you don't have to go into all the other negative signs. Okay. So suppose if it's a COPD patient, then what all things you have to look for. And again, I forgot to tell you, when you are looking for the general examination and the trachea, always look for the tracheal duct. Tracheal duct, that is, you keep the hand below the cricoid cartilage. You feel as though the hand is pulled down by the tracheal movement. That is called a tracheal duct. And then you measure the suprasternal notch to the cricoid cartilage distance, usually 2 to 3 fingers. And then look at the side of the chest wall for the indrawing of the intercostal spaces, which is called a Hoover's sign. Okay, so these 3 signs are signs of hyperinflation, clinical signs of hyperinflation, which give you an idea this patient may be having a chronic obstructive pulmonary disease or an emphysema. Okay, so when you are coming after the general examinations for the inspection, and then you are coming to confirm your findings, you always, when you are looking for the tracheal position, always look for the tracheal duct and the distance, and then you can look carefully for any indrawing of the intercostal spaces, that is the Hoover's sign, which give you an idea that this patient has got a hyperinflation. And also the anteroposterior diameter will be increased. Then that you can say that along with that. Okay, I have examined this patient, I am seeing some signs of hyperinflation, as there is anteroposterior diameter of the chest is increased, or there is a barrel-shaped chest. The Hoover's sign is positive, and the tracheal duct is there, and the suprasternal notch of cricoid distance is reduced by 2 fingers or 1 finger. So I have auscultated this patient who has widespread expiratory V's as well as coarse crackles. So I think this patient must be having a chronic obstructive airway disease, and if he is on oxygen, you can say he is on oxygen. So then the examiner will ask you how will you confirm your diagnosis and all those questions. Okay.
Because tumor is how common in emergency exam, and how to approach that case?
Tumor.
Pancoast syndrome or
No, usually we don't actually, unless there is an upper lobe tumor, for example. These patients are very sick patients, Of course, if there is a mass lesion, then you can see that the supraclavicular fossa will be full, either on the right or left. And if you percuss, there will be a dull percussion note because the generation of the sound is defective. And if you auscultate, the breath sound is diminished. Okay, there will not be any bronchial breathing. These are the characteristic findings, and then you can say, okay, of course there is a possibility of a mass lesion because the breath sound is diminished. There is normal vesicular breath sound, but in this particular area the breath sound is diminished, and there is a fullness of the supraclavicular fossa, and the percussion note is impaired. So I feel this patient may be having a mass lesion in the right or left upper lobe, which could be a carcinoma of the lung. And then in that case, you can look for any lymph nodes on either side that you have already examined. No? Okay.
Ptosis, other thing we have to mention on
Pardon?
the inspection, partial ptosis or the worsening of the muscle.
No need. No need. We are not much bothered, but of course it's very evident. In the general examination, you can say, okay, there is a wasting of the muscles or there is a ptosis, which we are not going to. If any candidate has not mentioned about that, we are not going to fail you. Okay. But general examination, staring at you and saying some findings, abnormal findings, you can mention them better because that gives a clue to the examiner that you are observing very well the general examination of the patient.
What about getting double pathology, like someone with interstitial lung disease and you will find features suggestive of wheezes or?
Yeah, you can get in that case, okay, interstitial lung disease, you are not expecting expiratory wheezes.
Yes.
If there are generalized diffuse polyphonic wheezes over the chest, and at the same time you have fine crackles in both bases, so and then there is a clubbing and cyanosis, then you can say this patient has got predominant interstitial lung disease, plus or minus there is a suggestion of a airway narrowing or a airway disease like the bronchial asthma, because I am hearing polyphonic wheezes. That can happen sometimes, okay.
How common is that normal chest, or if we have a normal chest finding, then what we will do?
Usually we don't keep a normal chest.
Okay, sir.
There will be something.
There.
So sometimes only the bronchial asthma. Last exam we kept a bronchial asthma patient, but by the time the candidate came, the wheezes have disappeared. So he said it's a normal chest. So then we gave a clue to the, suppose if this patient is dyspneic and you auscultated and there are some expiratory added sounds, what do you think? Then he said, okay, it could be bronchial asthma. But usually we don't keep, there will be some findings, definitely. So either it could be a chronic obstructive airway disease or an emphysema or a chronic bronchitis. These are the airway diseases which you keep, and then there will be something like that, okay. And bronchitis always think that when the patient you're examining, while you examine also the patient will go on coughing and there will be a sputum port by the side of the patient, okay, in bronchiectasis.
So time factor is the most challenging in respiratory.
That's right.
The way sir you examine.
Yeah, this is the way you have to examine, because I have seen, especially in a female patient, if you get a female chest case, you should always take it for granted the findings are the back.
Yes.
Because we will not keep a female patient for the anterior chest wall, because they will be reluctant to expose yourself, exposed by herself, and it is very difficult for you to examine the. So most of the time, if a female patient, take it for granted the findings are at the back. Okay, so that's why I'm saying 90% of the cases the findings are at the back. So don't waste your time by examining the front. But most of the candidates will come and waste their time for 6 minutes or 5 minutes in the anterior chest wall where there is nothing. You are not hearing anything. So that's why you are repeatedly examining. And then the examiner say, only 2 minutes left for you. Then you will come to the back and mess up everything and then miss all the important findings and fail in the exam. Then again, lobectomy and pneumonectomy, if you may have a confusion whether it's a lobectomy or a pneumonectomy. These cases are coming up in the exam. In a pneumonectomy, the whole lung is removed. So there will be a crowding of the ribs, one. There will be a drooping of the shoulder, and the trachea will be shifted to the same side. Because the other lung is compensatory emphysema, so that will also push the trachea to the opposite side. And when you auscultate, you may hear the breath sound from the other lung, because the other lung is expanding, compensating. Okay, so these are the clues which will give you that it's a pneumonectomy. If there is a crowding of the ribs, and if there is a drooping of the shoulder, and if there is a tracheal shift, then you can consider this patient has got a pneumonectomy. If it is a lobectomy, the scar may be both may be the same. But in a lobectomy, you may not find that much of crowding of the ribs. That much of drooping of the shoulder will not be there. And if it is upper lobe lobectomy, the lower lobe will expand. So you will have only a scar, but you may hear the diminished breath sound over that area. You understand? So that gives you a clue that whether it is a lobectomy or a pneumonectomy. Okay. Even if you say lobectomy or a pneumonectomy, we will not fail you. Suppose if a case of a pneumonectomy and you say it is a lobectomy. Okay, you say upper or lower lobectomy, you will not fail you because you have picked up that finding. Yes. It may be sometimes difficult, but if you have very carefully examined and looked for all these signs, then you may not miss. You will say pneumonectomy, then you will get a clear pass. Yeah. So some examiners, if you say a lobectomy instead of a pneumonectomy, in a patient with a pneumonectomy, then he may give a borderline. Okay, some examiners. But if you have picked up all the signs, most of the examiners will pass. Because with the calibration, we usually say, if the candidate picks up that there is some sort of a restriction of the lung, either lobectomy or pneumonectomy, then we'll have to give him a pass. We should not penalize him for missing that. But you look for these signs for a pneumonectomy exercise, but whatever the signs I told you. Okay.